My name is Sandro Galea. I have the privilege of serving as Dean of School of Public Health at WashU, and I'm here with Public Health Ideas. These are conversations that aim to highlight work relevant to public health from faculty across WashU. Today, I have the privilege of speaking with Professor Proscovia Nabunya. Professor Nabunya is Assistant Professor at the Washington University Brown School of Social Work. We're going to be discussing today her recent paper in the journal AIDS and Behavior called Preliminary Impact of Group-Based Interventions on Stigma and the Mental Health of Caregivers and Adolescents Living with HIV in Uganda. I'm looking forward to the conversation. Proscovia, welcome.
Thank you.
Tell us a little bit about the work that led up to this research.
Yeah. So my work is focused at the intersection of HIV treatment, prevention, and stigma interventions. So I'm particularly interested in interventions that address issues around HIV stigma among children and their caregivers. So for this intervention, which is really focused around addressing stigma among caregivers, it's a group-based intervention. There are two group-based interventions. One is we call the family strengthening intervention, which is focused on the entire family. So addressing issues of communication, responsibilities, where families facing the same challenges are brought together in a group to talk about their coping skills and support. So the second intervention is a group cognitive behavior therapy, which is evidence-based and has been implemented in various settings, including the US, to address issues around mental health stigma, but also improve HIV treatment adherence. So because in Sub-Saharan Africa, we do not have interventions to address issues around stigma, specifically among adolescents, so this was a low-hanging fruit because these are already there. So the question was, why don't we adapt these interventions that have worked, they're evidence-based, and see whether we can address these issues in Sub-Saharan Africa.
Let's talk about the issue for a second before we talk about the intervention.
Yeah.
So explain stigma in the context of Uganda, Sub-Saharan Africa broadly, and HIV stigma. So what do you mean by that? How does it manifest?
Yeah. So HIV stigma is at the core of both HIV prevention but also HIV treatment. So it manifests through stereotyping. So people who are living with HIV are stigmatized because of this infection. So, and it's primarily driven through how it is transmitted, so through the sexual intercourse. So what happens for children, we have about 1.4 million children who are born with the disease. So those have had nothing to do with the transmission, right? But they're growing up with a disease which is highly stigmatized. So what are we going to do with this population? They are growing, they're transitioning through adolescence. They also have to manage their HIV medication and at the same time manage an HIV stigmatized infection. So when people feel stigmatized or anticipate stigma, they do not take their medication, they do not enroll in care, and they're afraid to get tested for HIV because they don't know what is going to happen. So with that, it's a barrier to both preventing the infection, but also to promote, it's a barrier to treatment adherence and virus suppression, which all increase the risk of HIV transmission. How
common is stigma of HIV as a problem?
It is very common. And you may think that because the virus has been there for over 30 years, you may think that now we know. We have the information about how it transmitted. You would think that we no longer experience, that is no longer an issue, but unfortunately it is. And it manifests at different levels. So at the individual level, when people are stigmatized, family level, community level, in healthcare systems, there's a lot of data and research around how healthcare providers stigmatize people who are living with HIV. Children, women, they're denied access to healthcare because of their HIV infection, but also it's embedded in our national policies. So those structural barriers that criminalize, key populations, criminalize small amounts of drugs. So, and these are key populations that when you stigmatize them, when you criminalize those issues, then people go underground. They do not seek treatment, and then that increases the risk of HIV transmission. So it manifests at different levels, which means if we are to intervene, we have to think about multi-level interventions to address these issues.
Let's go to the paper then. So what was the key question you wanted to address with this paper?
So the key question, because these are interventions that are being implemented in other settings. I wanted to just test the feasibility and the acceptability in the low-resource setting in Uganda. So if we were to bring it, people would be able to use it. Are we able to enroll people in the program or in the intervention? But also, are there some preliminary impact that we can do? Because we need that pilot data before we take it to efficacy. So I wanted to see whether there is preliminary impact of these two interventions on addressing issues of stigma, improving treatment adherence among adolescents, but also around addressing issues of mental health within these families.
Tell us, what was this intervention?
So the two interventions are the family strengthening intervention, which has worked, which is part of an evidence-based intervention registry in the US, was originally developed to address issues of child behavior health. Now we are using it to address HIV stigma. We trained community healthcare workers and parent peers, so these are parents of school-going children, to be able to deliver that intervention. Then the second intervention is a group cognitive behavior therapy. For that, we trained counselors at health clinics. So this, because in low-resource settings, we don't have enough psychiatrists to be able to, to intervene in mental health issues. So the next big thing, the next best human resource that we have, they are health, community health care workers and counselors at the clinic level. And these are individuals who are now working with adolescents living with HIV.
And what did they get in intervention?
So for multiple family group, they get 10 sessions. It's a curriculum-based, there are 10 sessions, and it's focused on their 4 core components, what we call the 4 R's. So we talk about responsibilities, family rules, respect, and respectful communication within the family. But also we talk about support. How do you address stress within the family environment? And the reason is that usually children are not part of the decision-making within the household. So if things like, associated with stigma come up, or even coping strategies, they don't talk to their parents or caregivers about this. Okay, so this group setting, we put them together with their caregivers, but also other families experiencing the same issues, so caring for children living with HIV. So we bring them together to talk about all these issues and stigma as well. How are they coping? How it is manifesting their families? What can other families learn from that? And it takes 10 sessions. So the second intervention of group CBT, for that is focused on adolescents. So about 10 in a group. We don't engage we don't engage caregivers on that. And we focus on those core components of CBT, so psychoeducation skills. They talk about, relationship between their thoughts and emotions and how to avoid negative thoughts. So we give them, they go through those, those skills. And children enjoyed being part of those groups because they thought it's giving them an opportunity to even share with others going through similar experiences.
So what did you find?
Amazingly, so this study was awarded in 2020, right during the lockdown, right? And so recruitment, intervention, delivery were all done during that period. But we did find a positive results. So families, both for caregivers who enrolled in the multiple family group, we were able to see reduced stigma by association. And this is stigma where because your child is living with HIV, you're also stigmatized. You may not be HIV positive, but because a family member is living with HIV, you also feel stigmatized. So the multiple family group reduced those stigma by association at 3 and 6 months, and also reduced the stigmatizing attitudes, so HIV stigma and discrimination attitudes that caregivers hold. Now, when we talk when on the side of group cognitive behavior therapy, and remember, so in this intervention, caregivers did not participate, but those caregivers also reported reduced stigma attitudes. Now, how? Because they're not part of the intervention. Yes. So it could be that participants, when they attended the sessions, they took back the skills they learned and talked about them with their family members, because they can always share, and the goal of the the groups was really to share what you're learning with your family. Some multiple family group had homework, so what we call roadworks. So they come, they do activities at the venue, but they go back with their families and talk about things, and they do homework and they bring and share the next session. So both interventions also reduced mental distress and parenting stress over time. So these interventions showed us that in the short run, all these things can reduce.
What are the implications of an intervention like this in terms of scale up? Like how does this change such a complicated problem in a country?
Yeah, so that's a good question, and that's where I want my work to go. So the next step for this will be really to test the efficacy of the intervention before we, to inform scale up at the long run. But the beauty of this intervention is that they are group based, which means they are low cost compared to if you're doing an individual intervention. So in a low resource setting, where, like I said, the financial stability is an issue, but also human resource capacity to deliver this intervention. An implication is our ability to train the people who are already there, healthcare workers, parent peers, lay counselors within the clinic. So we use those resources that we have to be able to scale up. Okay, so we not hire new people. These are people within the community. They learn. We train them and they learn these skills. Outside of our intervention, they are still continuing to use the same skills in their daily work. Because these are family strengthening interventions that usually don't happen in our settings. So we plant the seed, and then these community healthcare workers can go on and incorporate those in their training. So in terms of scalability, this is something that is doable.
So where's your work going, intersecting with that?
So it's like the intersection is maybe at two more steps.
Two more steps, okay.
Yes, because I've put in a proposal to test the efficacy of this intervention, which is currently under review. But those findings then will inform whether we take this to scale or not. But hopefully we do.
I would look forward to that. Last question.
Yeah.
Are you hopeful about our trajectory, maybe as a world, or maybe as a region, in terms of stigma around HIV?
That's a good question. So I'm hopeful that some of these interventions are coming up, and we're using the evidence-based, and we are doing whatever we can to be able to do so. UNAIDS has, the 10% targets for addressing issues around stigma. We are not there yet. A few days ago, I was looking at the countries with that criminalize key populations. We are not there yet, okay? But we are taking steps. Now, in terms of what can we do? There are things we can leverage. So in HIV prevention, I'm very, very excited about long injecting, a PrEP for HIV prevention for adults and girls and young women in low resource settings. But there are also issues around access, right? Access, how long is it going to take us in low resource settings to be able to scale that up? But there is promise on that. Now, when it comes to stigma, there are new ways around leveraging, mobile health to be able to address these issues, right? So people who do not want to go to the clinics to get their medication or to access other HIV services, how do we leverage mHealth to be able to bring those services to them, or for them to be able to interact with their care providers? That way we are reducing stigma in a way, because then, the face-to-face or the barriers they are worried about, we cut them out. But we have a long way to go, because this is a disease that has been here for more than 3 decades. But the issue is still going on.
Well, Professor Nabunya, thank you for the work you're doing. Thank you for talking.
Thank you
for being
having
part
me.
of the conversation.